Hey everyone, this is Victor from Cyborg for Life, and today I have a very special interview for you. He is the head of 3D-Surgery at both the University of Munich and at Bethel Hospital in Berlin, Germany. Please enjoy the interview with Dr. Peter Thaller.
All right, everyone. Today we have a very special guest joining us. He's the head of 3D-Surgery at both the University of Munich and at Bethel Hospital in Berlin, Germany. With over 20 years of experience and having operated and supervised more than 1,000 lengthening procedures using the latest surgical methods and state-of-the-art devices, he's internationally recognized for his vast experience in the trifold field of limb length discrepancies, defects, and deformities, hence the term 3D surgery. He takes a hypercritical assessment of his patients' problems in order to strategically help them reach their goals, whether it be reconstructive surgery or to enhance their stature. Please join me in welcoming world-renowned orthopedic surgeon, Dr. Peter Thaller. Hey, Dr. Thaller, good morning. How are you doing?
Hello, Victor. I'm doing fine. Thank you very much.
Yes, definitely.
Before we start, I want to tell you that I really appreciate what you do. Lots of our patients are confused by controversy informations on the internet.
Mm-hmm.
And I think with your approach and your knowledge, which you have already, and you have a knowledge from medical and technical science, you provide a very good service for information for our patients.
Wow.
So thank you a lot, and I'm glad to be here.
Wow, that is a true honor to hear that coming from you. So I appreciate that kind compliment. When Dr. Donghoon Lee, he recommended you as a phenomenal surgeon. I was like, I have to get this guy on, so we can hear your valued perspective on limb lengthening. So now, before we begin, I just want to run through your qualifications. So you earned your medical degree and did residency at University of Munich, and you even earned your Master of Science degree in Advanced Orthopedics and Traumatology. On top of such an impressive medical background, you've also published several very interesting articles, developed various innovative surgical techniques, and take a scientific and experience-based approach to arrive at the best possible outcomes for your patients. So to start us off, Dr. Thaller, I just want to get a background of how you got interested in the field of limb lengthening and deformity correction.
That's a long story. I tried to make it short. At high school, I wasn't interested in medical science.
Interesting.
I was interested in arts, music. Actually, I was a dancer.
What?
At a ballet, and I was interested in sports. And the main emphasis of the last 2 years on high school was sports. But I didn't realize that it was a lot of theoretical work, studies in physiology, training science, biology, and this was the time when it really came the first time to my mind that I could become a doctor, because learning all these theoretical basics. So I was lucky to get a place at the University of Munich,
Mm-hmm.
which is one of the eldest and most honorable in Germany, the Ludwig Maximilians University.
Mm-hmm.
And I studied, and in the course of my studies, my PhD student's work was in plastic surgery on replantations of fingers.
Mm.
I examined some hundreds replanted fingers. And then I became the job here at the university clinic. And I was planning to become a surgeon, a general surgeon.
Okay.
So my first scientific work was on gastric ulcer bleeding and so on. And you pass several disciplines like emergency medicine and ICU, and then I became as a part-time job, a helicopter emergency doctor in the Austrian mountains for 10 years. I had a lot of fun and a lot of adventure. And in the late 90s, my course of training was into trauma, orthopedic and trauma surgeon, and I joined a group which called Department of Special Implants.
Okay.
And they had just released one of the first fully implantable lengthening nails.
Wow.
And that was where I got stuck and where our heart is now until now.
So that was the event that kind of set it all off with limb lengthening after that.
Yeah,
Very cool. Which implantable nail was that?
the fit bone.
The fit bone. Okay, very cool.
Yeah.
Awesome. Very cool. Awesome. Well, yeah, I actually want to kind of talk a little bit about the fully implantable lengthening nail, and get your perspective as a surgeon. So, I mean, you know that these implantable nails have changed the game in terms of limb lengthening coming from the external fixator. But how have you seen these non-invasive or minimally invasive devices impact, the things that you deal with at your practice, discrepancies, deformities, dwarfism, even cosmetic stature lengthening? How has it impacted your practice?
I think it was the game changer when in the late 80s,
Okay.
the first fully implantable nail was launched by Bliskunov, yeah?
Yeah.
And later on by the Albizia nail, also in the late 80s.
Yeah.
And those nails were quite, I call them the tanks of lengthening nails, because they were very robust and very simple. Both had a ratchet mechanism. The Bliskunov had a lever arm which was attached to the pelvis, and so if you moved, it clicked and it lengthened. And the Albizia nail, which had a nickname called Twist and Shout, because you had to twist it and it seemed to be painful. And then by chance I crossed this group of Fitbone inventors, and this was the next nail in the 1990. It was published by Augustin Beetz the first time. But actually then I learned that Munich has a much older history of fully implantable lengthening with a lengthening plate, which Professor Witt here in the Polyclinic did in the late 70s, a first case which was published.
Okay.
He also did distraction osteogenesis by an electric-driven lengthening plate.
Wow.
And so after that, I did a lot of fit bones, and the next generation was then a refined ratcheting nail, the ISKD, invented by Dean Cole. And then I came across a very smart guy, a French genius, Arnaud Souberon, who unfortunately passed away already in an accident. He was an inventor, and he invented the first magnetic-driven nail, the so-called Phoenix nail.
The Phoenix nail.
And I could gather a lot of experience with this nail also. We published this, and this was the first nail which was able to retract if we wanted to retract. So if you got a problem with lengthening, you could retract the nail and re-lengthen. Every implant was custom made. So I sent a design of nail to Arnaud, and he built it, and every single piece was really for the patient which was designed for. And it had so many advantages, especially in size. The thinnest nail was 8 millimeters. This was legendary.
Wow.
8 millimeters.
Yeah.
And then came the precise
now.
Which is now really state of the art, you can say. The first P1, it was a modular nail, didn't turn out to be as stable, and the company changed it very fast to the P2 and the second generation of the P2. And this is where we are now. And so the comfort for the patient is the best we ever had. The safety is the best we ever had. And so the indications for limb lengthening, which 30 years ago were 4 or 5 centimeters, the orthopedic surgeons who were not so much into the topic said, okay, stick to this 4 or 5 centimeters of leg length discrepancy, don't change it, because the risks were too high and everything was too difficult. So now our benchmark for lengthening is 2 centimeters, because risks are low, implants are comfortable, and next generations to come, like the nitinol nail, which I gathered some experience, and it keeps staying interesting for me.
Now, I do want to talk a little bit about your approach, because at 3D surgery, your practice, you take analysis and planning to another level very seriously, and the precision of your technique of bone alignment is, really, really important. So can you talk a little bit about, for example, why bone alignment and just having the precision of, making sure that the patient has alignment when they're done lengthening is so important?
Yes, it's all about alignment, because we know if your leg is malaligned, your joints will suffer, mostly the knee.
Okay.
And if you have if your mechanical axis of the knee is to the lateral, maybe bit more than 5 centimeters off-centered, to the medial, maybe until 10 millimeters off-centered, you have a relevant risk of getting an arthrosis sooner or later. So with a malalignment, you ruin your knee.
Wow.
And it starts with the examination.
Okay.
Every patient, every limb lengthening surgeon does a sorrowful examination. And then every limb lengthening surgeon, I hope, does a long-standing radiograph to check the alignment before the surgery.
Okay.
If the patient is aligned, good. But if you lengthen the femur, you lengthen along the femoral axis, so you lengthen into a valgus. The more you lengthen, the more the patient gets a valgus. So you have to anticipate all this, and it starts with an excellent long-standing radiograph. So if you don't have a good radiograph, you can't forget the rest. Then the analysis, you have to analyze the alignment and the joint angles. You have to measure to know, okay, this patient needs a plate, this patient needs a nail, this patient needs an external fixation. And there, the history of analysis and planning, it started with more than 100 years ago with Mikulicz.
Okay.
He was the first, Johann von Mikulicz. He was a Polish-German surgeon, I guess. He died in the, I think, 1905 or so. He first described the mechanical axis of a leg anatomically.
Okay.
And then other scientists later in the 80s, Cook and Moreland, they put it to another level because they were doing those long-standing radiographs, and they took it to the level of measurement of the joint angles and to more precise describe the proximal femur, the knee joint angles, the distal tibial angles. And then a group from Elizarov surgeons, Drop Haley and Kevin Tedsworth, published it and really made it popular among our groups, the malalignment test and all this. And this is what you need to measure very meticulously. And what those Elizarov surgeons did for analysis was the same what we do now, but with more modern means. In planning, it was different. In planning, the so-called CORA, the term CORA is a very essential term, you heard it maybe, but it's related to external fixation, where you can cut the bone wherever you want. Nowadays, we have to think about implant-related osteotomies. You cannot do the osteotomy wherever you want with a plate or with a nail. You have to adjust the level of osteotomy to the implant and more or less ignore the CORA. You have other technical means. So those terms from the external fixation planning, like osteotomy rules number 1, 2, and 3, we all learned this, do not longer apply. Now it's only about the mechanical axis. We have a planning technique since 20 years, which is called the endpoint first technique, which is quite comprehensive, simple to learn. And we teach this in our 3D surgery course. We drive an international 3D course in Istanbul many years, and the last was in Munich. And we teach these new planning methods for fully implantable systems, plates, nails, whatever.
Do you use any certain techniques, technology, or pre-op analysis or assessment tools to, plan for your patient's alignment?
Yes, sure. We have a standard long-standing radiograph, very standardized, lateral views and so on. There are other technical tools like EOS, the biplanar low-dose radiography, but still the gold standard is long-standing radiograph, lateral views, and if you have torsional problems, we add a torsional CT with a very low radiation dose, which isn't a problem to our patients. We have launched a program for analysis of long-standing radiographs based on artificial intelligence.
Okay.
So our measurement of joint angles and alignment and length, it lasts less than a second. The upload of the X-ray lasts longer than the result. This was a lot of work with hundreds of, you have to teach these these algorithms, analysis is important and planning is important if you do lengthening.
Yeah.
If you lengthen a cosmetic patient or do a bilateral lengthening on a tibia, you might do it without planning if you use the perfect entry point.
Right.
But if you only plan them, the very least patients have a perfect geometry. So we realign nearly all our patients.
Speaking of cosmetic lengthening patients, a lot of them, as it becomes more popular, people want to boost their stature to feel better about themselves. For you as a surgeon, when you get consultations from patients and people are asking, hey, doc, I want to get this amount of height or this amount of length, do you have a threshold of length that you will only allow the patient to lengthen up to? Or are there certain limits that you find that complications just exist at and you just won't go past that?
It is very, very individual.
Okay.
Just compare a patient with a leg length discrepancy after polio and a bilateral lengthening of a achondroplastic dwarf. You can lengthen 2 or 3 times more in the achondroplastic patient because all his soft tissues are the limitations. The bone is maybe you can lengthen it endless if the soft tissues and the joints would do it. So the next limitation is the implant. If you have a short implant, lengthening nail, you only have a short stroke. So the maximum stroke which you have at the moment is 80 millimeters, and we have lengthened a femur by 10 centimeters already, or a tibia by 11 centimeters already in limb lengthening patients, not in cosmetic patients. But we did this in 2 steps.
Yeah.
With a time in between for the soft tissue to recover.
Yeah, I think that's really important. Now, a lot of stature patients, they'll try to get maximum length. So if they wanted to get 2 surgeries, what's the time frame between surgeries that you most recommend for those soft tissues to recover? Is it a certain amount of weeks, months, years?
If really, I had only one cosmetic patient who wanted a second lengthening after having gained 12 centimeters, and I refused.
Okay.
But if the patient would fit, if the psychology is okay, if everything fits, I would recommend a year or 2 in between.
Okay, yeah, that's what I find most people just find. It gives them time to recover fully. Very cool. We briefly mentioned in our last discussion that you had a case with achondroplastic twins. I wanted to bring that up and talk about it.
And that's a nice story. Maybe 15 years ago, I guess, parents with achondroplastic twins, 2 boys, came to my office, and the boys were, I think, 15 years old, and they asked me to lengthen their children. But one of the boys said, how can you dare? I don't want to be lengthened. He was a little bit shy. The other said, yes, please lengthen me. He was in contact with his first girlfriend, and so the one had the lengthening, quadrilateral lengthening with at that time it were fit bones, yeah, for I think 10 or 12 centimeters.
Wow.
And the other said, okay, I will observe the case of my brother,
Great.
and then I will decide.
Okay.
So since most of the achondroplastic dwarfs have huge deformities, I also did a realignment in this guy who was lengthened. And after 2 or 3 years, the parents again brought the second son to have a lengthening.
Mm-hmm.
He at that time was 18, and he was a musician, a classical musician, and he played in 2 orchestras. And he said, no, I don't want to have lengthening. Please give me a realignment to save my joints,
Mm-hmm.
because my height is my brand in the orchestras.
Oh.
So this is a very nice story, which I tell to a lot of my patients. The characters are different and the needs are different. So every patient is a single piece to analyze, to also psychologically and medically, and 2 identical persons search for 2 totally different goals.
Yeah, that's really, really interesting because, you know, a lot of patients, they kind of just say, oh, they want to go for a certain amount, but these were twins, and you would think that they kind of think alike, like, oh, I want to be as tall as my brother. But in this case, you know, the other one was completely fine with his height. So that's very cool. Now, Dr. Thaller, I want to talk a little bit about, you know, patients when they undergo lengthening, regardless of what it's for, discrepancy or cosmetic. A lot of them fear things like non-unions, the bone not forming. Besides using things like appropriate weight bearing to stimulate, you know, osteogenesis, are there any other prophylactic measures that you take as a surgeon to help prevent these things from happening?
No, I don't. Another important success is the new fully weight bearable nail, which, to my concern, stimulates bone formation.
Okay.
And a problem with a total lack of bone formations, I can hardly remember 2 or 3 patients which then had to be reshortened and taken other measures and bone grafting. At the proximal femur, we never ever had problems with bone healing. At the distal femur, very rarely. We see after half a year, if you're very experienced, you can see it earlier, that there will be a lack of bone formation. And this is always on the lateral distal femur, to my experience. And then I check it for 1 or 2 or 3 months. And if it doesn't improve fast, I recommend a bone grafting, which is an easy and safe procedure. And then every bone healed, in my experience, in my last 20 years. At the tibia, it's the anterior cortex, which is the thickest cortical bone in our body. And as more cortex you have, the harder is the healing. And so we have just 2 weeks ago, I did a bone grafting in a lengthening patient. She had it's usually only a quarter of the circumference, which has a lack of regenerate. But if you remove the nail, it might cause instability in heavy loading, maybe. So it's an easy procedure to do a bone grafting, and then after half a year, everything is done and healed.
I see. And then what about things like, you know, preventing it, like such as using pain medication like NSAIDs?
Yes, good question. Thank you. That's a good question, because there is a controversy in the philosophies of all orthopedic surgeons, but especially those who do distraction osteogenesis are confronted with it. So 95% or more of the orthopedic surgeons, they use non-steroidal anti-inflammatory drugs as painkillers. They use it, for example, in hip replacement. If you do a change of a hip, you have a high risk of unintended calcification. Too much bone formation around this second surgery of the hip. So they give these medicaments, anti-inflammatory drugs,
Yeah.
to prevent those periarticular ossifications.
Okay.
The same surgeons who fix a broken bone also give from the first day or even during the surgery those anti-inflammatory drugs.
Yeah.
So as we know, healing is going through 3 steps.
Right.
And the first step, which lasts about 7 to 10 days, is called inflammation phase. So how can you think about enhancing bone healing if you inhibit the first phase? So there is a lot of evidence and a lot of literature, but still a controversy. So to make it short, my patients, as long as they need to grow bone, or at least in the first months, do not get anti-inflammatory drugs. They get calcium, vitamin D, as we all do. And later on, it's no problem, because there are first results that in research of tendon healing, anti-inflammatory drugs in the last phase, in the remodeling phase, help to do remodeling. But in the first phase of healing, the inflammation phase, it might be only a bit of inhibiting, but I don't need even this bit.
Right, right. That's really interesting, because I was always thinking about, and I was kind of mixed up in the controversy, because I was always a proponent of not taking it during my lengthening, and I had no problem. I could take it. I had a high pain tolerance, but some patients, they just take it anyway. But that's good to know that.
Yes. Sorry to interrupt. I'm a fan of ibuprofen. If somebody around says, "Oh, I have a little pain," I said, "Okay, take ibuprofen for 3 days." I myself sometimes take ibuprofen before I hike into the mountains, because I know that my Achilles tendon might hurt the next day. So I don't have a problem with. They are great, and they are very specific and very good painkillers.
Yeah.
But we have other non-opioid painkillers which are as effective for our patients. And if the patient is more, we add opioids, as you know, according to the WHO scheme. So we don't need those anti-inflammatory drugs for our patients.
That's really good to know. You had a really interesting published article on humerus lengthening, for patients who are either trying to balance with post-stature lengthening proportions or for dwarfism for functionality. Can you do deformity correction with an internal lengthening nail for humerus?
So first thing, the length of the humerus is not, or the arms is not as important as the legs.
Okay.
Second, the alignment of the arms, not the hand, the arm, the long bones of the arms, is not as important as in the legs.
Okay.
Length, if there are only few patients who need a lengthening of the humerus. I wouldn't recommend forearm lengthening, because there are 33 muscles to serve the fingers and the hand, and you would cause a disbalance, and you would get into real trouble with hand function. Besides, it's 2 bones and so on. So if the arm is too short, we lengthen the humerus. And coming back to your question, external fixation versus internal, it's much more comfortable. It's safer. And with those nails which we have now, we can do it.
Okay.
With the fit bones, they were too thick. The fit bone is, in its thinnest part, it's 11 millimeters only.
Yeah.
So the precise is 8.5. So we can use thinner nails for more of those humeri, which the nail fits. And our publication, which you quoted, it's a wake-up call for the nailing surgeons of the humerus, especially when you lengthen, because everybody does it antegrade, and if you do it antegrade, you go to the rotator cuff. This is not such a big problem. But then I was talking about implant-related osteotomies. The osteotomy is done in the upper third somewhere, but the insertion of the deltoid muscle is from the mid third to the lower third. So it would be much, I will explain why, much more favorable to do the osteotomy below the deltoid insertion. And you can only do the osteotomy below the deltoid insertion if you use a retrograde technique because of the properties of the nail. And now the anatomy. There is the deltoid is inserting very deep in the arm, deeper as you think. And when you do the osteotomy between the proximal humerus and the deltoid, you cause a lot of pressure. This pressure either damages your rotator cuff or damages your deltoid and your axillaris nerve. So, to my concern, you must lengthen below the insertion of the deltoid.
Muscle contracture, would it be?
I wouldn't expect.
No, you wouldn't expect.
Biceps and triceps are quite flexible. I haven't had problems with that.
Okay, very cool. Well, that is really interesting to know that the retrograde approach is more effective for that. And then I also know that you use a really interesting tool in your article. It mentioned a steel sleeve for when you're doing tell us a little bit about that. That's really interesting.
Yes, we developed this very early in the early 2000s, and actually I was presenting it to the public first time in 2003, when a very good friend of mine, Bruce Foster in Adelaide, Australia, invited me to do the first fully implantable lengthenings in the Southern Hemisphere in Australia. So we had two young boys, we did surgery, and he organized a camera team, and I held it into it wasn't published scientifically yet, so it was broadcasted in Australia first. So the thing is, we impact those steel sleeves. We define the perfect entry point according to our planning, and then we impact those sleeves into the bone, some centimeters. This enables us to do a 18 millimeter skin incision, enables us to protect, especially for retrograde femur, the knee from all these debris and bleeding and cartilage and bone. It enables us to use rigid reamers, which, as you know, the bone, the tibia and the femur are bent, and a lengthening nail cannot be bent because it wouldn't be stable. So we have to insert a straight implant into a bent bone. And you can only straighten the bone if you use rigid reamers. We call them rigid reamers. Actually, they are millers because they go where you want. And most of the lengthening surgeons, they use flexible reamers and they over-ream the medullary canal. And this enables them to insert a straight implant, but it's a loss of stability. So these sleeves also protect the bone from those rigid reamers to damage the entry point. And many other advantages. We use it in so many instances, even for removal. We can do minimal invasive removal with those steel sleeves. So we love them, and this is now the third generation we use already. And you mentioned Donghoon Lee. He came to Munich and he said, I want those sleeves, and he wanted them urgently. And he uses them also,
That's amazing. I love that. I love the innovations that surgeons come up with, because it really is, changing the game and pushing it forward in terms of limb lengthening. Very cool. Dr. Thaller, I want to talk a little bit about, a lot of patients are wondering if they're too old for lengthening, whether it be for whatever reason. What's your take on the ideal age range for optimal healing? Is there a certain age that a patient should just deal with their condition, or can there be, as old as, let's say, 50, 60 years old?
Very easy answer, the younger the better. But I have to differentiate. In children, you hardly use lengthening nails because of the growth plates and the dimensions of the bone. We did lengthen a few children with open growth plate, And I was discussing this with Bruce Foster in Australia. He did some research on growth plate issues. And I asked him first with the first case, and yes, you can do it if you perforate the growth plate centered.
Okay.
So there is no disturbance in growth. And interestingly enough, we saw that the nail which was blocked above the growth plate of the distal femur, the nail was, and the lengthening was above that, and the growth plate pulled the end of the nail into the bone.
Wow.
And this is a proof that the growth plate continued to grow even during lengthening.
Wow.
So this is an exception.
Yeah.
But usually we don't do surgeries in patients with open growth plates. So the first patients are 10, 12, 11, 10, 12, 13, as soon as the growth plates are closed.
Okay.
So they have the best bone formation,
Okay.
for sure.
Right.
But this lasts for some decades where the bone formation is good. And only in really elder patients, the bone formation is not as good. But I have a 76-year-old male, not for lengthening, but for bone transport, who had a very good bone formation in bone transport. And as we know, this procedure of distraction osteogenesis stimulates a lot of vascularization of the leg, for example, of growth factors. And there is a method which we also use. We do transverse distraction in diabetic feet. So a patient has a wound of the foot which cannot heal. So we do a callus distraction osteogenesis on his tibia, where he has no wound and nothing, and we stimulate a lengthening transversely and push it back. And we see that we have brilliant healing of this diabetic foot. So distraction osteogenesis causes healing. And there is a saying from Elizarov. He says, infection burns in the fire of distraction osteogenesis. So we dare to lengthen elder patients too, sure.
Now, you mentioned a little bit about the growth factors as lengthening takes place, and that's what I want to ask you about next. Is some patients after lengthening, they notice that their leg muscles will grow, hypertrophy after lengthening. I've always kind of, been a little, kind of hesitant to kind of like dive in and anticipate about what this could be about. But what's your take about why the muscles around the bone that's lengthened could grow? I was always thinking maybe it's the stress on the muscle, maybe a fasciotomy. What is your take?
I don't think that in the standard patient, after lengthening, the muscle grows because I have lengthened him.
Okay.
There is one thing where muscle is enhanced in our patients because of the fasciotomies. We, until 2003, we had 3 or 4 patients who suffered from a compartment syndrome because of a tibial lengthening. And this is a severe complication where you have to react immediately. And if you don't react immediately, a patient has damage for life. So in 2003, we started we built on our own a mini fasciotome where we could use the same stab incision, which we use for the drill bit osteotomy. We did an opening of the most severely endangered compartment, the tibialis anterior compartment, with those mini fasciotome. And so we did a minimal invasive fasciotomy in all our patients with tibial lengthening since then.
Wow.
And there is a PhD student who just finished his work. We will publish that soon.
Okay.
And he examined all those patients retrospectively. And in, I think, 33 patients, he invited them and he measured the force of the dorsiflexion. The midterm observation period was, I think, 6 years. So in average, 6 years after the surgery. And he found that there is a minor, very minor loss of force in those tibialis anterior muscles compared to the other side, a 10% loss, which is not, the patients were not aware, they don't feel it in sports. So there is a minor loss of force, even though the muscle is bigger in those, a little bit bigger. Yeah, you won't see it, but if you measure it, the muscle is a little bit more bulky because the fascia is open.
Right.
So this means the fascia is a means for the blood transport back to the heart. You need it because otherwise you get thrombosis in the lower leg. So those four compartments are important. And also this fascia is a little bit, seems to be only a very little bit important for the force this muscle can develop.
I see.
So long story short, I don't think that lengthening causes enhancement of muscles. It's the training afterwards. If you do a lot of training, you can train it up. Fasciotomy causes a minor improvement of volume, a minor improvement, and a very minor improvement, loss of force.
I see. Yeah, that's really interesting. I didn't even think about the force keeping the muscles compact. Very cool. Now, Dr. Thaller, in your recently published editorial in December 2020 on the future of deformity correction, you briefly mentioned some advancements in, some technology that may be coming out, such as a new actuator technology. You mentioned it at the beginning a little bit about the nitinol magnetic-driven nails that may be on the horizon. In fact, your colleague, Dr. Metin Küçükkaya in Istanbul, Turkey, he actually implanted the first one. Now, I do want to ask about, with their amazingly distractive abilities and unique structure about how their memory-shaped alloys, do you think that they will be as effective as the current technology, or for treating things like limb length discrepancies, defects, deformities, and just regular lengthening?
Since I was a consultant for these Finnish guys, which are very smart, I'm not a consultant anymore because now I'm a consultant with invasive and I cannot consult two groups. But I was for a few years, and my very good friend Metin in Istanbul, with whom I do those courses and so on, he was also from the start. Things I can tell is the nitinol technology is, to me, endlessly strong. So the force of this nitinol with those micro movements, you cannot stop this power. Yeah. So one thing is they will be powerful, but at the moment we don't have problem with power because the magnetic nail is working quite well. And in contrary to the Phoenix nail, which I told before you the story, the Precise has a gearing which enhances the power, and I never had problem with power. I cannot tell too much. I'm observing this, very interested. Metin has now 5 clinical cases. He does a clinical study. Wow. And at the time when we tested them in human cadavers, it proved to work. But it's a long way of a new technology to invent. But watch this space. It will be interesting for me too.
Absolutely. I know that nickel titanium is a very strong, alloy, so that should be interesting. Now, I want to talk about a little bit about your patients who come to see you for lengthening. Do you require your patients to stay on, the clinic site, or can they come get lengthening and then go to local housing or go back home and then, visit every few weeks for checkups?
Yes, our patients stay in the clinic for a week or sometimes less than a week.
Okay.
And where we teach them to ambulate on crutches if we don't have the fully implantable nails, but the fully weight bearable nails, even those with the fully weight bearable nails, they leave the hospital with crutches.
Okay.
Because it's you cannot start immediately to fully weight bear. So important is safety first. So I tend to see my patients every week or latest every second week.
Okay.
So some patients from Europe they fly in every second week.
Mm-hmm.
If a patient has really problems to see me, and the process of lengthening is smart and fine, I would insist on seeing him every third week latest.
Okay.
So if a patient is not able to show up every at least third, or it depends on the character and on the case. Yeah, a lengthening of 2 centimeters is not a thing. Yeah,
Right.
but difficult cases, I would really need to see every week, second or at least third week.
I see. That makes sense. Physiotherapy. What do you have physiotherapy at your clinic, or is it like at an affiliated center nearby, or do you recommend they do it near their living quarters? What type of setup do you have there?
We have a very good physiotherapy at the clinic for sure.
Mm-hmm.
Now in Berlin, my second branch since a year in Berlin, they have a even better than at the university, really brilliant physiotherapies and very good equipment and resources.
Mm-hmm.
But the clinic is the minor part. So every patient has to provide or to get in touch with a physiotherapist close to his home, wherever he lives. And we have standards for those, a handout, and the physiotherapist is not the most important. The most important physiotherapy is once or twice or 3 times a week. Most important is many times daily exercise and the right exercise of the patient. You know this best. There is not much effort in 3 times half an hour physiotherapy per week.
Yeah.
So the patient must exercise every day, several times. And it's just the task of the physiotherapist to instruct him, to review if he does the right thing. And that's why I want to see my patients very often, because even those physiotherapists, which I don't know in most times, I don't know if they do a good job. So I want to see if the patient does his work, if he does the right work. I need to see the distraction process.
Mm-hmm.
But more important is if he does the right physiotherapy and if he ambulates correctly and so on, because this is the key to success.
Absolutely. Yeah, because you don't want the soft tissues to lock up. Well, that was amazing. Dr. Thaller, you're a true genius when it comes to critically analyzing and planning for outstanding patient success. As a very experienced surgeon for patients in Germany and the surrounding European countries, patients are going to want to reach out to you. So are there any ways that they can find out more information about you and contact you?
Yes, the best is our websites,
Okay.
3D-surgery.de, which is for Germany, which is for my clinic in Munich, and 3D-surgery.org, which is the clinic in Berlin.
Okay.
It's most easy.
I'll make sure to put all your contact information in the show notes. And Dr. Thaller, do you have any final words to patients who are considering limb lengthening?
Yes, sure. My most important message is get always a second opinion.
Mm-hmm.
If patients buy a refrigerator, they go to Amazon, they check the scores, they go to the shops, and they decide on every detail before they buy a refrigerator.
Mm-hmm.
But many, many patients get lengthening at the first specialist they know. So specialists for limb lengthening are not so many, because the caseload for these surgeries is low, but it's worth to travel some 100 kilometers and then to decide. So I tell this to every patient in every concern. Even if you get the thyroid operation or so, if you have time to it's no emergency like a bone defect or other reconstructive procedures. Limb lengthening is an elective surgery, so you have time to get a second opinion.
Okay.
And then I have different tips for the 3 groups of lengthening patients. If you have a leg length discrepancy, just search for a surgeon, take a second opinion, and then go for it. If you suffer from dwarfism, it's totally different. Then you remember the twins.
Yeah.
Think about how much you need it and how much you also have some risks. Yeah. Think about and if you really think you need it, do the same. Search for a surgeon, get for a second opinion, and then also go for it.
Okay.
For stature lengthening in normal-sized persons, it's even more important because they are totally healthy.
Right.
Really consider, do you need this? And if you really think you need it, go even for a third opinion to find the right surgeon for you.
Yes. Yeah. Yeah, that makes complete sense. And that's why I'm trying to do this whole YouTube thing, is just to really bring that information to people, say, hey, these are the best surgeons in the world here. Not only that, but to educate themselves and be very informed about the process, because the surgeon can do so much, but the patient also has a responsibility to educate themselves. So very cool. Well, everyone, that is Dr. Peter Thaller of 3D-Surgery at Bethel Hospital in Berlin, Germany. Dr. Thaller, thank you so much for your time.
Thank you, Victor. I'm very proud to support your project. And whenever you need my advice, please don't hesitate.
Absolutely.
All the best.
Thank you.
I hope you enjoyed the interview with Dr. Thaller. With legendary talent that takes surgical precision to another level, the innovations and contributions he's made to the field of limb lengthening are truly remarkable, as is the way that he cares for his patients' long-term health by ensuring that they end up with outstanding results. If you're interested in reaching out to Dr. Thaller and his team, I've posted his contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.